It's recording, right? Oh, because that's should stop recording or pause recording. Okay. All right, is he good?
Ask him if he can hear us talking. Can he like say something just so we know we can hear him too?
Can you say something? Tell him he's, there he goes.
I've never watched his videos.
No.
Is our speaker?
Hello?
I just like can't.
Is it chat if he has a question? But he can hear us.
I just like.
Yeah.
Yeah, he says he can use the chat, if that's.
Like those kind of things. I just like can't. Okay.
Or unmuted, yeah.
Try. Tell him to try again.
Try it one more time.
Hello?
Oh, okay. Well, okay. All right, we'll just keep going from now. And so if there's an issue, I may or may not see the chat as one of the other problems, so you can call or text you or whatever. If-
We're still missing one in all of this. We can find out who it is. I'm not sure. He's the one that's Zoom and there's still one more. I believe. What else are we missing? Huh? Yes. Yes.
Okay. Okay.
Or
Okay. Hi. Sorry about all of that. We've been having Zoom issues forever, and usually he's not always here available. So anyway, trying to get this going. Set. Let's get this. How do I? Okay. So is this the PowerPoint that's on Leo for you guys?
Yes.
Okay. And like I've been saying this entire time, this is another one that I have spent a lot of time on updating, so please don't disregard this after today. So objectives for today would be to describe skin complaints, diagnose common skin complaints, and then evidence-based plans of care for the common skin complaints. And I've already told you guys about that. In Bob review, we are not doing. Okay, so I know you guys haven't seen this in the Bob because we're not doing that at the moment, but if you saw this with Bob complaining of itching, blistering between his toes, and exposure to campground shower and this skin finding, what would you be thinking? Sorry, I can't hear you.
Oh, sorry, athlete's foot.
Okay, and what's the other name for that? Or pedis?
Oh, sorry, pedis, yeah.
Yes. Okay. And how would you describe his feet out of these? Okay, perfect. Whoops, sorry, I'm clicking way too much and we already did that. All right, so this is the next thing that you just mentioned, the tinea cruris. Okay, so commonly in those skin foldings, that is like armpit area, axilla area, very common there, very common in the groin. And then also under the breasts is also very common additional area. All the places where it's a little bit hard to keep dry and not to be sweating there. So you'll see that a lot. So for those, typically topical antifungal creams for 10 to 14 days. But these infections are very stubborn. Any of the fungal infections are very stubborn. So with babies, for example, when they have like the thrush things, or the diaper rash fungal infections. And that's why I have this in parentheses, is that the 10 to 14 days is usually about how long it takes, but you have to tell the patient to apply it for that amount of time until the rash looks completely like it's gone, and then for 2 more days after that. If they do it for another couple days, it will just come right back. So it's very important to include those 2 days. Okay, and then here's tinea versicolor. Sorry, this font is a little bit small. So by Malassezia fervor, common areas, chest, neck, back, and the proximal arms. A lot of the time you'll do the ketoconazole shampoo. You can do the oral ketoconazole. A lot of the times we try topical regimens first. We'll talk about other ones that are a little bit more resistant, but if you can do the topical and they respond, great. But the systemic treatments are not quite as benign. So we'll try that first. Tinea corporis. Here's a couple examples. A lot of times, like the ringworm type appearance. So history is very important. In kiddos, typically kiddos is where you can have confusion with nummular eczema. So it's important to get that good history. Think about the time of the year. Is the rest of their skin dry? Is it, so, humid climate? Are they taking baths every day? Do they have a cat? Were they playing in dirt or in a sandbox at daycare? All those kinds of things. Is there anybody else in the family with it? And the nice thing with derm is that a lot of the time, steroid creams or antifungals are our top 2 things that we very commonly prescribe. If it doesn't get better with one, you can try the other. The drawback is that with these fungal infections, if you feed it steroids, it can get a lot worse. So, you'll know pretty quickly if you were wrong, but history is probably the best thing in differentiating this with tinea corporis. Okay. So KOH scraping is very helpful with any of these tinea infections. If it's pretty bad, if they have one spot, a topical is usually going to be fine. If they're immunocompromised, they have it everywhere. A topical is going to be pretty difficult to manage it. So you may have to do the systemic. If I'm going to give somebody systemic treatment, what do I need to watch? It's in the blood work. Liver enzymes. Good. You need to actually get baseline liver enzymes, and you should get a confirmation diagnosis. And that's why it means a confirming diagnosis before you just give somebody systemic antifungals. Okay. Tinea pedis, it can start like that. I've seen it like this pretty commonly as well. It looks kind of different. So you just want to have both of those pictures in mind. Okay. Let me see if there's anything else that we haven't talked about. Okay, so this is one of the things, like whenever I'm talking about toenail removals, for example, with ingrown toenails, a lot of the tinea pedis and ingrown toenail type people, they're very commonly associated, and they'll have, and a lot of the time it's my like 14, 15-year-olds that are super sweaty and hormonal and nasty socks, nasty shoes. And so I preach to them that if this is going to go away, they have to change. I mean, it's not their fault that they're going through all of that, but because of that, they're going to have to probably change their socks in the middle of the day and alternate their shoes if they, at least with one other pair if possible, right? And make sure they're showering every day. Or this will not go away. So on that note, with like thrush, for example, with babies, again, can be persistent if, and it's a nystatin, oral nystatin that we give for babies. And, you know, if they're adults, they swish it, spit it out. Babies obviously like, can't do that, right? So we have something called gentian violet that you may have seen. It's like a purple dye. It gets all over their tongue and mouth. They literally paint it in their mouth everywhere. And then we give them a nystatin liquid to just kind of put in there the best they can to try to treat it. But again, if they aren't staying on top of sterilizing the bottles, the pacifiers, and it can be transferred to mom if mom is breastfeeding, to her breasts where she can have a fungal infection there, and then they're just passing it back and forth. So you have to a lot of time keep all that in mind. I've had residents before where they just have this and won't go away, and that's because they forgot, oh, the pacifier, I was sterilizing the bottles but I forgot about the pacifier. Or again, like with mom, sometimes you have to treat mom and treat the baby, or it just won't go away. And baby sometimes has pretty poor feeding, poor weight gain with that, because it's uncomfortable. Okay. Talked about that. Okay. Tinea capitis. So a couple different ranges that you can see here, but here a pretty classic finding is where you can see that there's no hair. The hair breaks at the follicles. You can see that happening. Let's see. So the other thing to keep in mind with tinea capitis is that they can commonly get a secondary infection. So these superimposed infections called carry-ons that are typically staph related, because the tinea capitis is itchy and they'll just, you know, scratch at it. And in women with yeast infection, so again, a fungal type infection, you know, that's the biggest complaint they have, is that they're itching in the vaginal area. But in kids, you know, like their scalp will be itchy and they're just scratching and have dirty hands, dirty fingernails, and they're just inoculating nasty stuff there. So a lot of the time you'll have to give them an antibiotic in addition to an antifungal to help get rid of that.
The antibiotic, what do you usually use? For MRSA?
With that, a lot of the time we just treat it as MSSA and see if it gets better, like a mupirocin type thing. But because and you know, obviously if it doesn't get better, then you can convert, but we try to avoid just going straight to like an MRSA type infection. Yeah, so mupirocin is pretty common. So these are our treatment options for the systemic treatments. And you can see that these are very long treatments, much longer than we see with most things that we give. So 6 to 12 weeks for a lot of things. Again, because they're very stubborn. And these are what are typically given. So you can do it with tinea capitis, and I think, sorry, I can't remember if I've already, okay. With tinea pedis, you know, like if it's in the toenails itself with like onychomycosis, that is probably the most stubborn out of all of them when it's living in the nail bed. Sometimes we have to remove the toenail to help get rid of it, you know, especially if they can't tolerate a systemic option. You know, if they have liver disease and you if you want to avoid this at all costs, if possible, if they're already having something like that at baseline. But 6 to 12 weeks, taking it every day, and it's not the most fun, but in a lot of the time they kind of lose faith in it because it's forever long treatment, and the toenails grow very slowly, so they don't see, it's not going to make the already infected toenail look better. It's going to just change what grows out, and you know how slowly that happens. So sometimes they just think that it's not working. So it's a lot of patient education with that goes along with that too. Okay,
Everybody's trying to get in.
I'm sorry.
Everybody's trying to get in up top.
Oh, okay. Thank you for letting me know. Okay. So then here's an example of a carry-on like I was talking about. Okay, what is your answer for this? Yes. Okay. So, see if there's anything else in there that we haven't. Okay. So erythrasma, it's a Corynebacterium, same type of places that you'll see that tinea corporis, that's the intertragus areas. Usually like not really itchy like the other. I mean, it can be, but not nearly as bad as what you'll see or that patients will describe. But you can see it on the Woods lamp. Again, same thing, like you're gonna need to keep it clean, but you'll do the miconazole or erythromycin for that one. Okay. And what's your answer on this? So that's the one that we were just talking about with the erythrasma. Okay, there's onychomycosis. Okay, so there's some examples, you know, not really bad at all here. This is really bad. I mean, you'd probably want to almost start from scratch with those. But, and, you know, and with the way that their toes look, it looks like they have a lot of other things going on, probably diabetic, but you can see some of the tinea pedis up here with like these little satellite lesions up this way too. So, all right. And here is the steroid potency table. So you'll just want to kind of know one or two from each of these categories, just so that whenever you're prescribing them for patients that you have examples of what things to pull into your mind whenever you're trying to prescribe things as you move from mild, moderate to potent with what you're trying to give. Most things you're not going to just start off with high potency steroids. Okay, so what would you want to do for Bob's tinea pedis? What did you say? Okay, that was it. Yes. So you definitely could, and he very well could respond. Again, I think it's totally fine to start with the topical and move to oral if needed. So yes, that is an acceptable answer, and that's what I would start with. It wasn't that bad. Okay, so move towards skin cancer. This is the same mnemonic you've probably seen a million times, even if you're not in medical school. So, and then yearly appointments, especially if they have a history of skin cancer, I would have them be seeing dermatology every year. Okay. And this is another example, but really about the same type of information. Okay. All right. What is your answer for this? Okay, a lot of different answers. All right. So D, surgical excision for whoever said that, I think it was over there. So here is the reasoning, okay? So for the squamous cell greater than 20 millimeters, then you need surgical excision with 6 millimeter margins, and you need to remember that, okay? So if it's less than 1 centimeter, you have other options, but this is a pretty decently sized one. So so higher potential for Mets. So that's why they have that sort of surgical excision being the preferred treatment. Okay. There's a lovely squamous cell, but I don't know why she like it that big, but all kinds of reasons. People are scared to go to the doctor a lot of the time. So, but there's that for you. And there's another one. Okay. So, lots of the time will be areas where they had lots of sun exposure, face, their arms, right? And so history again is important. A lot of the people with this generation believed in full sunbathing and did not really protect their skin as we know a little bit better now. So for this, if it's less than, so on the surgical excision, if it's larger, larger tumors, so like it said, 6 millimeters, you want a margin of excision, sorry, a 6 millimeter margin of excision, like it said on that other slide. Okay. Basal cell. So again, you guys are going to be looking for key words: rolled edges, pearly gray borders with telangiectasia, central ulceration. Those are all buzzwords that you'll want to remember for here on out. And full thickness biopsy. This one you'll want 4 millimeter clear margins, or Mohs surgery if they're large or aggressive. And then those key areas where you really don't want to cut very cosmetically sensitive areas: nose, ears, lips, like with the vermilion border, things like that. You can do desiccation and curettage. You can do imiquimod, and that's 6 weeks if it's less than 2 centimeters and if it's not in the H zone, which I think I have a slide of that. There it is, yeah. So H zone, those are the high risk areas. Again, you'll want to remember that. Those areas you want to take very careful precautions, get super clear margins with those. You really don't want to mess around if it's in those areas. Okay, what's your answer for this? Yes, good. Okay. What about this one? Yes. And why is E your answer? Yes, and it's in that high risk area, right, in that H zone.
Desiccation.
So let me see if I can. So it's, I don't even know how to navigate this thing, but a lot of the time you'll have a, oh, what is it called? Where you're almost like burning the skin type of thing, but you really, what is it? Yes, very similar to that. Like what you're almost doing cautery, but it's like you're cutting but cauterizing at the same time. Oh, do you have it pulled up? Okay.
Like burning it out.
Yeah.
Burning it, let's scrape it out.
Yes. Yes. Okay. What is your answer for this? So remember those H areas, the mask areas of the face, and then the sizes. So even if it's a low risk location, so not in an H area, if it's greater than 20 millimeters, then it has a high risk of recurrence. Okay. So here's a pyogenic granuloma. These are benign, they don't look good. And if it was somewhere else on the face, you might mistake it for something else, but they're commonly in those mucosal regions, and they grow fast. So again, like patients are pretty scared of it, but they're vascular. And a lot of the time though, as opposed to cancerous findings, it's usually after some type of trauma. And a lot of times it's like they bit their lip really hard or something like that type of a thing. And then they have to get it, to really get it gone. A lot of times you have to excise it. And sometimes it'll almost burst on its own and then it just comes back. And so to really keep it gone, they have to have it excised, which I don't do in those areas. Those are very cosmetically sensitive areas. So I send them to ENT for those usually. All right, so this is a lentigo maligna, typically large in size, greater than 6 millimeters. It can be very irregular, all kinds of different pigmentation types, usually smooth, but you need a 3 millimeter margin for those. And then this is a lentigo maligna melanoma. So these typically you'll see very much darker blue, black, like they spilled ink appearance, but can become invasive melanoma. So you want to treat them seriously and get them quickly over to derm. Okay. And then a superficial spreading melanoma. So these are different, where a lot of the other ones, they go deeply. This one it stays superficial, but they typically stay superficial, but the degree of how things will worsen depends on the thickness. So they still want to get a measurement of the thickness. They just don't tend to go as deep, but the deeper it is, the worse outcome, just like with other things, obviously. But a lot of times these will be wider than thick. Okay. Okay, And so with these, they will typically do a lymphadenectomy and sentinel lymph node biopsy because of their propensity to metastasize. And so that's something else that you'll commonly see with those. Okay. Nodular melanoma, they look very strange. So patients will definitely come in with these. They're not really questioning if it's something serious or not. Again, you'll want to get this diagnosed very quickly, biopsied, excised with a 2 to 3 centimeter margin, and have it removed. Acral lentiginous melanoma. Okay, so with this, you can see how it, it's on that edge of the toe. Sometimes you'll have it where you can see something just starting under the toenail. So if you have anything like that, again, you'll want to have a low threshold for biopsy or a low threshold for sending them to derm, because this does not go well typically if you just let it continue. So you want to give them the opportunity to go ahead and have that diagnosis sooner rather than later. A lot of times people will just ignore those things whenever they think it's just like a bruise or something under their toe, or they stub their toe and then they just let it keep going and going. Okay, so for that acral, this is the excisional margins that you want to have for that. Again, a lymphadenectomy, sentinel lymph node biopsy. And here's some subungual melanomas. So anytime you see, with derm, whenever you're trying to look at lesions, one of the things that helps a lot is by looking at the rest of their body, right? They'll come and say, there's this one thing right here that I'm concerned about. And so some of the biggest help is by looking at the rest of their body, right? And similarly, if they have a melanoma in their toenail, it's not going to usually be all of their toenails happening all at the same time, right? It starts there and spreads within that toenail. So if all their toes look a little different, then, they look, all their toenails look the same with those same spots, and it's not as likely, right? But if there's one that looks very different than the rest, then you play that game. What's one thing that looks different than the others? Then you would have a low threshold. And they can be something like this, very flat, or like that. And can metastasize, so you want to take it seriously. AKs, actinic keratosis, we alluded to earlier. I think the treatment's on the next slide. Yes. So can predispose to a squamous cell, so you do want to treat it. There's lots of people that walk around with AKs for years and years and years and never do anything about it. But they can turn into something else. So treating it would be better. A lot of the time, it's not just one lesion, right? It's like their whole arm or their whole scalp as they bald or whatever be the case. And so you can do cryotherapy or you can do excision, but if you're talking about their entire scalp or both of their entire arms, that'll be a little bit difficult, right? So you'll see derm use 5-fluorouracil or imiquimod, and where the patient is applying that, and they just have to let them know that a lot of the time it will make the lesions look a lot worse initially. They'll get really red and angry, and then slowly get better, but some will just stop using it because they said that it makes it worse. But you have to, patient education and letting them know that's going to happen is a pretty key. Okay, keratoacanthomas. So again, from sun damaged skin, but as opposed to the flat sandpapery type feeling, these erupt outward. And again, you can do cryotherapy or excision. Okay, Lyme disease. You guys have heard all of these probably a million times. Tick bite with rash with central clearing. History is very important. Prevention would be very important. Rocky Mountain spotted fever. So with these, let's see. So remember that for it to be a Rocky Mountain spotted fever, they have to have a fever, right? So if they just have this rash, you really don't want to call it that. They'll have a fever. Their body is not going to like it. But they'll also have some of these other symptoms. And then remember, the rash begins on the legs or arms and then spreads to the trunk, spreads centrally, which you'll need to remember that to differentiate it from other things, right? And then the symptoms usually start 3 to 14 days after the tick bite. If the tick was only on them for a few hours, they're not going to have Rocky Mountain spotted fever. It has to attach and stay attached. And so some people freak out very quickly about that, but it needs to be attached, and then they just didn't notice it for a couple of days, and then they develop these symptoms. Okay. Chickenpox or varicella zoster virus, we don't really ever see. Your guys' generation all probably had the I can't think of words today, sorry, vaccinations for them. I'm a little bit older than you guys, and I had chickenpox. So yeah, don't really say more except for immunocompromised people, or if they didn't get their vaccines and then was around somebody with it. But you will want to remember with chickenpox versus other things that you'll see it in a variety of stages on their body, right? So like see on here how there's some ones that are just starting, and then this has erupted. So this one's a little bit newer than this one. This one's much older, right? It's already popped and started to scab over, and then it'll go away. But see how there's all different stages of lesions on this picture, right? So that's something that you'll want to keep in mind. And then you can see like here, there's that early crusting that you can't really see it on this picture, but in real life, there'll be like yellow crusting on some of the lesions. Okay. Supportive care, there's not really much to do. That's why, but I mean, we have the vaccines now, so you really don't see it anymore. But if you needed to, you'd give them the cyclovirs. Okay, scabies, typically very itchy, and the description is multiple small erythematous papules, often excoriated because it is itchy, and you treat it with permethrin cream. So I put this baby on here because I had a kiddo once many years ago that he was probably about this young, but he was his skin was all very dry, and multiple people had thought that it was eczema even before me. So we were like just intensifying his eczema treatment, but come to find out it was scabies, which it's not super uncommon. I don't run across it a lot. Eczema is much more common, but that's one thing that some people do mistake scabies for. It was like eczema versus scabies, and so you want to keep that in mind and see if you can find some other signs, like if you can see it, in the webbed area between the fingers. But in babies, it can be a little bit more difficult, and they're a little more on the immunocompromised side. So, you wouldn't really see this in an adult, but in a kiddo, this is a little bit more common. Okay.
Super like fussy and unhappy.
He was fine. He did scratch at it, but no, he behaviorally he was okay. Okay, rosacea, chronic inflammatory skin disorder, and you'll see these these classic little bumps that rise up on the face very commonly in these areas right here. But the centrofacial redness with telangiectasias and multiple erythematous papules is the description that you would be looking for. Okay. Psoriasis, very well demarcated, super classic findings, and I mean, and you will see this with core scaling. Okay. Sorry, this is blocking my. Okay, so PUPs or PEP, it's fair-skinned patients where you'll see a little bit of like this white halo. You see that in that picture around erythematous papules and plaques, super itchy erythematous papules with stria. And so see that how it's along this stria there. And then spares the periumbilical skin. Okay. All right. She did not give me one. We're gonna play a game.
So west side versus the east side.
South versus. South.
It's definitely west, possibly.
It's like.
That's east,
This is west. I'm using my compass on my phone.
Yeah, I just have it at eight.
So proud of you. Well, I would have said the same thing though. West is,
No.
yeah, but like without this.
Cause I just walked over.
I realize right now that most of the time I go.
So there is this like where.
I'm gonna-
So
I'm gonna
it's
work
like-
for
it's like 5 minutes.
Yeah.
So.
You got this.
Well, in the ocean, I don't know.
Run big next door. I almost like to say, I was just thinking where we were and I was like, oh. No, I don't think- And then one of the best pictures I've ever taken. It was like, I was shocked. Like you took the picture and I go, oh, that's actually really good. This is on my grandparents' fridge. I was like, here.
But yeah.
It's really one of the best pictures I've taken. No, look at me now.
Yeah.
This was also from. These three.
Oh my gosh. Okay. And then until and then put those other
Okay.
two.
Okay. All right, so I don't forget, whose was Dr. Underhill? If you can take that, we, all of your preceptors have been getting them, so it's not like just Dr. Underhill. It's like just other ones, I mean, there are a couple that if I can get thank you cards made, then I'll get that done, but the other ones, students have already earlier this year taken it back to them, we just haven't had anybody take one in.
Dr.
No
Nice-
special treatment.
Dr. Nice told me to tell you hello.
Oh, okay. Good.
That's
Yes,
so
I miss her. Okay. I have. I usually try to do 4 teams, but let's see.
That's.
Okay,
No, we're not.
let me see if she can get this other one to work. If not, then we'll have to do
We're
3.
probably all wrong.
Okay, let's do you 2 together and then you 3. Then can you 2, and I'll try to see if we can get another.
Oh, wait, no, it has white.
Oh, cool.
Yeah. No way.
What do you do there?
Jeopardy.
That was fancy. Like
Yeah, right. What is it? I remember the people part.
Sorry. Good luck.
First I thought it was like, he's like, oh, here, he gave this to you, and I was like, oh, it's the opposite. So you're the best student he's had. I think it's yeah, I thought they were.
I did too. I was like, wow, I wanna win.
Yeah.
A candle? Can't get the battery fixed on that. Rothwell and Pennick, who's with those? And then Rothwell. Nobody here, okay. Rothwell hasn't had a bag yet, so if you can stay for a minute.
For Pennick?
Yeah, or sorry, Pennick, yes, then we can get her a bag too.
Okay, I don't know if she's in. I'm with a whole bunch of random people.
Okay, well, you can
But I'll
just
just see who's
bring
there.
it and leave it for
Okay.
her.
Okay. Oh, yeah, I know.
Okay. Sullivan and Emily. If, let's see. Where did your other bathroom? Yeah, okay. Oh, I think Shandy maybe got it. Did you? Yes, it's not lined up. Okay, thanks. Okay, so then that can be yours. And I guess if you want, like, they can respond by text. This is how we did it last month. I guess we can put Emily on, did either of you have Emily's number? Then,
Yeah, I never remember.
okay, Emily, if you can hear me, if you, the questions will be on the screen. And so if you want to like text into your group and help with anything, you can. Do either of you have Sullivan's number?
I do.
Okay, and then Sullivan, you'll be with one of the groups as well, so that you can text in your contributing remarks. And then I need 2 people to help with. Okay, so we'll do scoring if one of you on that side can do scoring up there. I don't know how familiar you guys are with Jeopardy, but and then I'll need one of you to help cross off the questions that we've done on this board. Okay. Yes. And then just in case you're not familiar, we'll just have to pick somebody that gets to start. But if you, so somebody will get to choose which category, which question. And then the question is open to everybody. Whoever rings in first gets to answer. If you get it right, you get positive of that number of points. If you get it wrong, it's negative of that points. And then I think there's one double Jeopardy question on there. So if you get that, you can gamble how many of your points that you want to potentially up to double. And then we'll have a final Jeopardy question at the end. Okay,
Did we have to answer the form of the question?
no, you don't have to do that. Okay, let's see. And then, oh, and I will max you out to getting to choose 3 in a row. Just in case a team is on a roll, that way somebody else can pick a question. Okay. Awesome, thank you.
Starting to start buzzing on this. See how everything else
How
is.
do I, oh, how, okay, it's, hold on, sorry, I think it's on a different PowerPoint. Don't look. Okay. Okay, so let's start with you guys. That you guys can pick first, but anybody will be able to answer. Okay. And then we'll try to cross off on this board as we go. Oh, I need the instructions.
Yeah, I think that's fair.
What'd you say? Infections for 300. Okay, everybody get ready to buzz
I
in.
remember that, yeah. That was so
When can we buzz? Just so it's just a question.
As soon as I start, as soon as you can see the question, yes, you can technically buzz in. Okay. I don't have a prize. I did bring a bunch of candy last week. You can take it all. Okay, ready, go. I don't remember if the blinking one is the one or somebody else buzz in that hasn't, and just so I can see.
I think
Does
the
it-
solid
oh, it's coming
one-
down.
I think the solid one's first.
Yeah, the blinking is second.
Okay, thank you. Okay, so then yellow is which group? Okay. Okay. Oh, this is the daily double? Dang it, sorry.
Oh, my answer right here is good. I'm gonna say an oral or a topical antifungal.
Okay, what, and yes, and for you get the credit, but for learning purposes, what would be one of the names that for
Itraconazole.
I think you have to reshare your screen for Zoom.
oh, I'm sorry. Great, yes. Okay, no,
Click the little yellow thing. Share it.
okay.
What would you put on the test there, oral or topical?
I would do oral for if it's affecting the nails. Topical is not gonna really do anything. All right, sorry, that was the daily double, so that's the only one. Okay. Hold on, I need to move this thing so it doesn't keep.
Usually it's a death.
I move this out of the way.
Oh.
Okay,
What's that?
300.
For what team? Yellow?
Yellow.
Okay, so you guys got it right, so you get to pick the next one.
In theory, it should be like alcohol.
Look over, you're laughing, you're like. Oh my gosh.
Oh, it's cheating. You said vectors, so that's not- We're gonna do infections for 5.
Okay. What's your final answer?
Warm compresses.
That's correct. Good. Yes.
We're gonna do infections for 4.
Infections for 4. Okay, ready, go.
Just trying to hit it fast.
I'll get it wrong, for all I care.
I just want to hit it faster.
I don't know what that is. Do we need to get like a specific drug or just like a class? And root?
I cannot answer that question.
Interesting. Oral antibiotic.
That is not correct.
Oh, does that mean we get to use
Yeah.
That means yes.
Well, we were.
It was.
I would go with like a topical Pearson.
That is not correct.
Yeah, surgical.
Surgical drainage.
Drainage is correct.
What is it?
Oh my gosh, what is the name of it's, hold on, there's a really weird name. It's an infection just around under the nail. What did you say?
Carry ungool or
Yeah, there's another, hold on.
something.
If somebody can find the answer for what I'm looking for, you can get 100 points back.
For the name of like the issue.
Yes,
Oh, paronychia?
yes, paronychia.
You have to control the source. Gosh. Oh, that's so bad.
Okay. So green gets 100 points for naming that.
Where? What?
No, you.
What?
She went up there. She
No,
got
you're
400.
not seeing this up
Yeah,
there.
but we got extra.
For what?
Because she found what it's called.
Oh, okay.
I said whoever can tell me the name. Yeah, 100.
So we get extra points if we look it up in the notes,
Well, for that one, because I couldn't. Okay. So you guys got that one, so you get to pick the next.
Protocols. 400.
400. Okay, ready, go.
I don't understand.
Our thing is faster.
It must be, our thing is broken.
Okay, what's your answer? Accutane, yeah. That's your treadmill. Good. Okay. 400. Man, 400.
Joe, you at least got to get a second to read. You were asking, you said, what is it? No, you said, yeah. Oh. It works. I guess, yeah, you're right. Okay.
All right, ready? What do you want next?
We already did. So 2. You go for 500? No.
Why would you judge us? You got it.
I was thinking about him. Infections for 2.
Infections for 2. Okay, ready, go. Oh, green.
That was really aggressive. Lyme disease.
That's correct.
Which was that?
Retry this.
Yes.
Would it have been better if it didn't?
Sorry,
I pressed mine on accident. Okay.
All right, so you guys get to pick the next one.
Just finish infections.
Okay, ready, go. Yellow.
Bolts of Potato?
You can pick the next one.
I mean.
I'll try to.
Alright, big C for 500.
Big C 500. Okay, ready?
Who? Someone cheated. Was it you? It was clearly you.
It was close, I'm not gonna lie, you guys. It was really close. I got a little excited. You can't look challenging.
I know.
I know. So are we?
Big C 5. I'm gonna let them choose. If they,
I think we should have to trade the button between team members.
Yeah. So we're answering.
No.
Wait. Okay. That's what we're
Sorry,
answering.
go Is it a character I can't tell that?
Yes, it
Should I
is.
say that?
You already answered.
Well, I know, but
Wait, you have 3 guys there?
No.
Yeah, it's Coretta.
Oh,
You
so
can
then they
know
were
them.
second?
Wait, what was it?
It doesn't really look like the yellow. No.
You guys? So I.
There's still a lot of points left. And there's a double jeopardy. Don't forget.
We're gonna go define that legion for 500.
Okay. Ready? Blue.
Wait, define it, like, describe it?
Hold on. Which it says define that lesion 500. Okay. Yes, describe.
Like, just describe what we see?
Yes.
Ulcerated lesion with surrounding area.
Yes. And you can also say erosion, and so either one would be right. Yeah.
Okay.
Good.
I get 400.
I got 400.
Yeah.
Yeah. I don't think. Maybe you guys.
Okay, so we're gonna do the big C for.
The big C 400. Okay. Ready? Blue.
Nasty girl.
You know what? Just put your phone, let's hold both of them.
Yeah.
The big C for 300.
Big C 300. Okay. Ready? Yellow.
Is that us? Oh, no.
Yellow. Almost.
5-fluorouracil.
Yes, that would be acceptable. Yes, so you could do cryo or you can only see parts, you don't know how extensive. If it's just, like maybe 5-6 lesions, you could do cryo, but 5-fluorouracil would also be acceptable. So yes.
It's hard to keep out with the rash.
I think it's open. Yes, it's open.
Let's name that rash. A rash does that.
Rash 500. Ready?
We're gonna say measles, it's a maculopapular rash.
Yes, that is correct.
We're gonna do potables for 5.
Okay. Ready?
No, I swear, that was actually quick.
It's when you can see the question. Because when I click it,
I mean,
it doesn't actually, it's when I let go.
Like, read
That
it out
is-
loud and make them wait till the very end. But the rest of us can buzz back.
I mean, we can let you guys answer this one first. You're second, I mean, like.
We don't know the answer for sure, so we're gonna let you guys answer. Do you guys want the option to answer first? You want them to answer?
Yeah.
Okay.
I don't think we know. I don't think we have an answer.
Okay, well, then that's negative 500 for you. Please. I'm sorry.
It'll be okay.
Okay, so, since you guys got it wrong, now I don't know how to do this. Usually, yes, it would go,
We can guess.
Okay.
Molly Tran has a lot. That's a trust me.
that is correct.
They do biopsy or LFTs?
I will be honest, I did not create this question. So it's probably both, honestly. You probably do, I mean, and the patients that I've seen, they usually do, I see LFTs, but I don't know at what point they would do liver biopsies. And this could be old. Sorry, let me go back. Potent potables for 300. Ready? Go. Green.
Like retinols.
That's right. So 300.
I had so.
300, yes. Mhm. Okay, you guys get to pick again. Ready? Orange.
Except, okay, moderate.
Cortisone? It, no,
Number 2.
should be here. Let's, somebody pull up that and read off the moderates.
Acid moderate is clobetasol and
Oh shoot, I should have let somebody else go.
Oh, we were saying.
yeah, he did say triamcinolone.
Yeah.
Okay,
Yeah.
okay, so then you guys can get credit.
So,
200.
I know what to do. It has mid.
How about I give you 100 points?
Okay, that's okay.
Plus, wait, so only minus 100 or plus? 100?
Okay.
Sorry.
I guess only minus 100.
The lower mid version.
Okay.
I just got excited about having a life.
I'm so excited. It's a big time when you get your first.
Okay, so you orange, or no, yellow picks
Let's go name that ration 4.
4. Okay, ready? Yellow.
So wait, do we describe it or diagnose it?
Diagnose it is more of what they,
Spider bite?
yes. What kind of a spider would you, what kind of a spider would you be concerned about? Okay, yes. Brown recluse.
Is the bite from this drastically different for a population?
You can, no, not really. You can get like necrosis of the skin with either of those. So that's that, and some other things. Right.
I don't think you're like Photoshop, like whatever the pictures are.
Okay. So you guys get to pick. Okay.
Let's go the same category for 3.
Ready?
Yes. Scabies.
Yes. And that's just 2 in a row. That's just 2 in a row, right?
Yes.
Okay,
Yes.
so you get to pick another one.
Yeah, name that ration 2.
Green rush for 2. Okay. Ready? Yellow.
Yeah. Yesterday. Secondary syphilis.
Correct. Okay, so let Orange pick a question.
Oh, wow. Okay. Yeah, we're gonna buzz it. Define that lesion. Wait. I still have to buzz in, right? Okay, yeah, define that lesion.
Ready?
Wait.
Do we have to name the specific organism? Or can we, okay. Neopetus, moccasin type.
Okay. Yeah, okay. Yes, there is tinea pedis. The answer here says
Oh,
bullae, but that's only part of it. So like I said, I was not the one that came up with these pictures and questions and answers. So yes, I will take that.
Is it superimposed like bacterial infection? Is that what you're saying?
Mm-hmm. I've just never had anybody actually say tinea pedis as an answer, but it's definitely there. Okay. So you guys can pick.
We'll just finish off the rash.
Rash 100. Okay. Ready? Blue.
It's just a little, yeah.
So. allergic reactions
Calm down.
Okay. That was Rash 100.
The big C for 20 or for 200.
Big C 200. Okay, ready?
Oh my god. Okay,
What, sorry?
melanoma.
Yes. Easy peasy. Is everybody positive now?
Yeah, I think so.
Yay. All right, 1, 2, 3, 4 questions and then final Jeopardy. Okay, so Orange gets to pick the next question.
Wait. You want to use it? Okay, did you?
Wait for her to finish marking. Okay. Ready?
Really nailed it.
Your second.
Okay, green. These
Define that lesion for 200.
200. Ready? Blue. Describe or whatever. Name, describe, whichever. Yes. With surrounding erythema. Okay.
Oh, define that lesion for 30 minutes. That's still.
Yes. Okay.
Okay, yeah, we'll do that.
Ready? Orange. Mhm.
That one was
Scaling, what would be your second word?
Scaling surrounding everything it is. Oh, like, are you asking about, scaling class?
Yes.
Okay.
I was like, I know you know it. You just yes, scaling plaque. Okay, wait, is hold on. I guess there is two. Okay, I didn't see this one. So these two are left, the 100 and 100. Okay, ready, go. Green. Yes. Basal cell. Yep. All right. Last one. Everybody ready? Okay, green.
Benign, nevus.
Okay, yeah. A macule, hyperpigmented macule, but nevus that'd be fine too. Yeah. Okay, so that's 100. Okay, I am going to pull up. Okay, so everybody, I guess probably don't have paper. Hold on. Okay, so one paper per group. You're going to write down how much you are putting up. You can bet up to whatever you have. So if you have 500, you can bet up to 500 or bet only 300. If you get it right, then you get that many points. If you get it wrong, you lose that many points. So you're going to write how much you're betting and write your answer down on your paper. I'm going to pull up the question. They didn't close out of it. Oh man, they logged out and then where'd it go?
Oh, I see what you're saying.
Hold on, I thought I emailed it to myself and I don't see it. 1 second.
Oh, I see. Yeah.
Okay. I am going to. I'm going to give you 2 minutes. Okay. Let me make it bigger. How do I make it bigger? Hold on. How do I make it bigger? Okay, can everybody, hold on. Ah! Can everybody read that now? Okay. And the music is not timed with the time. 1 minute. Thirty seconds. Ten seconds. Time. Okay. So traditionally, it starts with the, oh, can you, let's see, I should have had us tally scores. So we have,
I will be on my- This is what, 1800?
what did
It's
you,
like over 3,000.
3,200? Okay. Okay. So blue, then we'll start actually. So how much, oh, so start with your answer first. They answer and then they say how much they bid.
Okay, we said staff scalded skin. All of it, 300.
And that is correct.
Oh, nice.
Good job. Orange, what did you come up with?
Not the right answer.
And how much did you bid?
400.
Okay. And then green,
We said staff scalded skin.
1,800. Okay. So you guys are currently in the lead. Let's see what yellow did.
We also said staff scalded skin,
Okay.
and we wagered.
Oh.
Oh my gosh.
Oh my gosh.
Dirty. Okay.
Alex
Well,
corrected that.
well, congratulations. Hope you guys had fun. Study hard.
That was good.
Good. Let me get you, let me write it out of card really quick.
We did.
My goodie bag. Claire, don't get the.
Yeah, she said she was just.
Yeah, it's pretty warm.
Like, yeah, almost 90.
It's like, yeah, it's awesome.
It's, I'm like sweating.
Like that t-shirt? You know, is it good?
I don't know, I have to wait. Well, if you change your mind, just let us know. Okay. Yeah, I just. Okay, now, okay, I think, yeah, I think I'm, oh. It's your life, honey. Oh, so like, distinguish. Oh, okay, gotcha. You're welcome. Right side. Push.